Started soon. I'm just going to do a introduction. So, as everybody knows, this is Dr. Francis Yao. He completed his residency and GI fellowship at Stanford. He's a professor of medicine at UCSF and serves as the medical director of the UCSF liver transplant program. He also directs the UCSF liver transplant outreach and community liaison program. Dr. Yao's research is focused on liver cancer treatment, particularly as related to liver transplants, as well as hepatitis B infection and outcomes for patients undergoing liver transplantation. Thank you so much today, Dr. Yao, for being here to discuss liver transplant for HCC.
Yeah, thanks, Amy, for the introduction, and good morning, everyone. It's great for me to participate in Grand Rounds. I see that Neil Mehta is here. I want to thank him for doing all the work that I present today. So just giving you a historic perspective, our approach to selecting patients for liver transplantation has really evolved in the last 2 decades. The Milan criteria clearly established liver transplant as a curative treatment for early stage HCC. You can see the criteria: single lesion up to 5 centimeters, or 2 to 3 lesions up to 3 centimeters. Really the benchmark for selection of candidates for transplant. But for over a decade, we debated about whether these criteria were too restrictive. So we had debates about expanded criteria, including the UCSF criteria, up to 7 criteria, and many others. But our thinking has really changed in more recent years. We are now, rather than solely relying on tumor morphology, we are now paying more attention to markers of tumor biology, such as response to local regional therapy and downstaging, and also tumor markers. And currently, both downstaging and AFP have been formally incorporated into treatment guidelines as well as national policies. So just quickly touch on expanded criteria. The idea of expansion has been compared to the Euro Metro ticket, with the concept of the further the distance, the higher the price. The further you go beyond Milan criteria, the greater the price you pay for HCC recurrence. You can see that many criteria have been proposed. Some were just beyond the boundaries of the Milan criteria, and others are further down the distance and much more liberal. Now, the Metro ticket concept has been supported by actual pathologic data, explant pathology, on over 1,000 patients collected by Dr. Marcifero himself, who developed the Milan criteria. And this is using a registry format. So you can see that the greater the tumor burden going to the right side, the higher the risk of recurrence, or lower the survival. Now, the Milan criteria, you can see that the expected 5-year survival rate is in the 65 to 75% range. The UCSF criteria cover a very small area in the Metro ticket, and in the shaded area represent those within UCSF, but beyond Milan criteria, the projected 5-year survival was in the 60 to 70% range. And then the up to 7 criteria, which means the sum of the tumor number and the largest tumor diameter equals 7, like single lesion up to 6 centimeters or 2 lesions up to 5 centimeters, the expected survival is around 60%. Now, as waiting time increases, local regional therapy like chemoembolization or Y90 radioembolization are being increasingly used and critically important as a bridge to liver transplantation, even though we don't have level 1 evidence that these treatments reduce the risk of dropout. In a Markov model analysis, treatment is cost-effective if the waiting time is sufficiently long. So these days, treatment should be done to slow tumor progression if the waiting time is expected to be at least 6 months. This is a paper published by Ellison Kwong, who used to be a fellow here, who worked with Neil and myself in this paper, just looking at the trend for local regional therapy over time, you can see that the pink area represent no treatment over the years. There is a greater proportion of patients receiving at least one treatment, and even higher proportion of those receiving at least 2 or more treatments. And you can see that the Y90, the use of Y90 has increased parallel the decrease in the use of chemoembolization. Ablation still pretty steady, about 20 to 25%. So, 90% of patients now, while they're waiting for transplant, receive some form of local regional therapy. As I mentioned, that we've seen a shift, a paradigm shift, or shift in focus in terms of how to select patients. Rather than relying solely on morphologic parameters, we are now putting more weight on tumor biology, markers of tumor biology, including response to local regional therapy, AFP, and possibly other biomarkers. We advocate this ablate and wait principle, which means that we wait to observe response to local regional therapy and then try to observe biology of the tumor. And that, in combination of tumor markers, are really the main driver for refining our selection of candidates for liver transplantation. These biomarkers include AFP, AFP-L3, DCP, and also the inflammatory biomarker, neutrophil lymphocyte ratio. We'll go over these in a few minutes. Now, currently in the United States, patients are eligible for receiving priority listing or MELD exception if the tumors are within T2 criteria, part of Milan. T1 means a single lesion less than 2 centimeters. These patients are not eligible for liver transplant priority listing, only T2 within Milan criteria. And the other group that now receive automatic MELD exception are the ones that have been successfully downstaged to within Milan criteria, using the criteria as shown here, proposed by our group at UCSF. Now, this is a very thoughtful paper by Massafero on how to prioritize HCC patients for transplant based on urgency and also utilization. Now, patients who are successfully downstage to meet transplant criteria is at the top of this proposed prioritization scheme, since these patients are likely going to derive the greatest transplant benefit. Now, downstaging combined expanded criteria with response to local regional therapy is defined as reduction in the size of tumor using local regional therapy to meet acceptable criteria for transplant. And tumor response should be based on radiographic measurement of the size of all viable tumors, and we don't count the area of necrosis from local regional therapy. So the fundamental principle behind downstaging is that it serves as a selection tool for tumors with more favorable biology that respond to downstaging treatment. And also these are the ones who are more likely going to do well after liver transplantation. Now, downstaging is dear to my heart, something I've worked on since like the early 2000s. So these are our inclusion criteria. No vascular invasion on imaging, single lesion about 5 centimeters up to 8 centimeters, 2 to 3 lesions, each up to 5 centimeters, with total tumor diameter up to 8 centimeters. And we also included 4 or 5 lesions, none over 3 centimeters, with total tumor diameter also up to 8 centimeters. This is an example of a patient with an 8 centimeter tumor who was treated with chemoembolization, undergoing downstaging, initially beyond Milan. And you can see the area of necrosis here. The tumor, the viable tumor is already within Milan. And our approach is to continue treatment until they achieve complete tumor necrosis going into transplant. I can tell you that you can see a patient showing this type of response, this patient is going to do very well after transplant. So this is the latest publication of our downstaging experience back in 2015. Criteria are shown here. 118 patients were enrolled. About a third had dropped out from the waiting list, and 64 patients ultimately underwent liver transplantation after successful downstaging. And we mandate a minimal observation period of 3 months with no treatment to observe for tumor behavior before we transplant them. And our outcomes are very good after a median follow-up of close to 4 years, less than 10% recurrence, 5-year post-transplant survival is 78%, recurrence-free probability over 90%, and then intentions to treat survival at 5 years was respectable at 56%, which take into consideration waitlist mortality. And when we look at post-transplant outcome comparing to the group within Milan from the outset, there's really no difference at about 80%. So we should, just think about, like, now we can achieve 5-year survival after transplant of 80% for HCC patients. And within Milan, or if they are successfully downstage to Milan, you can achieve 5-year survival of close to 80%. So I think that we're making some progress here. This is a separate study performed by Neil Mehta, looking at 3 centers in Region 5. Our goal for this study is to really look at factors that predict treatment failure, which we define as dropout because of tumor progression, liver-related death without transplant, or post-transplant HCC recurrent. And the 2 factors that we identified to be independent predictors of treatment failure are when patients have child B or C cirrhosis, and also high AFP, at least 1,000. And then when patients have both of these risk factors, these negative predictors, you have 100% failure rate. So these patients, the ones with decompensated cirrhosis, child B and C, with very high AFP, at least 1,000, presenting to you, it's really not realistic to even consider downstaging for these patients because of very, very high failure rate. Now, Dr. Mesafaro, it surprised me that he actually did a randomized control study in, comparing transplant versus no transplant associated with downstaging. So this is a multi-center phase 2B and 3 randomized control trial involving 9 Italian centers. The eligible patients include those with initial tumors beyond Milan, no vascular invasion. By imaging, they had projected 5-year survival over 50% based on the Metro ticket, and they have child A or B cirrhosis, and they performed downstaging with local, regional, surgical, or systemic therapy. And after initial observation of 3 months, 45 patients with either complete or partial response were randomized 1-to-1 to liver transplant versus non-transplant therapies. The numbers are pretty small here. And you can see that the liver transplant group had superior outcomes in terms of both tumor-free survival and overall survival compared to the control group receiving non-transplant therapies. So the study was terminated prematurely because of clear advantage in the liver transplant group. So the study raised the level of evidence supporting the benefits of tumor downstaging followed by liver transplantation. I don't think there will be another randomized control study being done. Now, this is a US multi-center retrospective study comparing the long-term outcome of those within Milan versus those successfully downstage and those beyond Milan criteria. We are part of this multi-center study, and this is providing 10-year follow-up. You can see that those successfully downstage within Milan, based on the UNOS or UCSF downstaging criteria, they have similar, slightly lower 10-year survival compared to Milan, but not statistically significant, whereas those with tumors being transplanted when they were beyond malign criteria has significantly worse 10-year survival. You can look at the recurrence and similar recurrence rate between those within malign at the outset and those successfully downstage, whereas much higher recurrence rate in the beyond malign group. So this is another validation of downstaging. And with all the work that Neil has done, we developed a consortium to prospectively evaluate tumor downstaging in the US. We named this the FAASLD Consortium. Neil does all the work, and I come up with acronyms every time. So FAASLD refers to multi-center evaluation of reduction in tumor size before liver transplantation. These are the 7 participating centers. We now added 1 or 2 of these centers. So in the first publication from the FAASLD Consortium, a total of 209 patients meeting the UNOS downstaging criteria were analyzed, and we see that the 2-year probability of successful downstaging is actually very good, close to 90%. So it illustrates that this is not a kind of, depending on single center, it can be done across the board. There's no difference in the probability of successful downstaging or liver transplantation between those treated with chemoembolization versus those treated with Y90 radioembolization. One of the key findings here is that tumor understaging based on explant tumors beyond malign criteria was actually found in a substantial percentage of patients, over 40%. And the sum of the number of viable tumors and the largest tumor diameter on the last imaging was the only significant predictor of understaging. So the message here is that we can do better still, and perhaps we should do more local regional therapy to reduce the viable tumor burden before transplant to reduce the understaging rate. This is the BCLC staging classification, the most commonly used staging system for HCC, and the recently updated BCLC have now recognized and integrated downstaging for liver transplant in their treatment algorithm and also expanded criteria. So, so I think that there's the feeling that all the work, over the years finally came to fruition. So now, can we push the envelope further? So at UCSF, we also explore the feasibility of downstaging under what we call the all-comers protocol, which means that the initial tumor burden is even beyond the UCSF or UNOS downstaging criteria. And we require a longer period of observation, at least 6 months, to ensure stability prior to liver transplantation. And this is a single center experience from our center, 74 patients enrolled in the all-comers protocol. You can see that almost 2/3 could be successfully downstaged to malign initially. However, there's a very high percentage of these patients being removed from the waiting list because of tumor progression, and I think in large part because of our long waiting time. So ultimately, only 10 out of these patients underwent liver transplantation. So our intention to treat outcome is not very good with the all-comers protocol. An important observation here is that there's a very strong correlation between tumor burden based on the sum of the tumor number and the largest tumor diameter and the probability of successful downstaging. You can see that this probability goes down with increasing tumor burden if at this threshold of sum of the tumor number and largest diameter of 12, the probability of successful downstaging falls to under 50%. So this is an important observation for us to follow in terms of deciding whether somebody is reasonable to undergo downstaging. In terms of how these patients do after liver transplantation, the data are very limited. This is an analysis of the UNOS data. You can see that the 3-year survival similar between the groups within Milan from the outset and those successfully downstage to Milan using the UNOS criteria, and then somewhat lower at 3 years survival for the all-comers group. This is a study by Ansa Huang, who was a fellow here. I think that she's here, joining us in grand rounds. So this is a nice study analyzing the waitlist outcome for all comers downstaging. So this is a major challenge. If you try to downstage these patients with very high tumor burden, you're also faced with a significant risk of waitlist removal because of tumor progression. So this is a contour report showing the variation in the waitlist dropout according to tumor diameter, AFP, and a different cutoff for the MEL score. So for a MEL score of 10, that means that this patient is pretty well compensated. You have a realistic chance of limiting the waitlist removal rate to 25 to 30%, whereas at a MEL of 20 is almost impossible to achieve that. So the waitlist outcome is expected to be much higher than 1 out of 3. Looking at it from a different perspective, if you have a patient with total tumor diameter of 10 and AFP of 100, for the patient with MEL of 10, the probability of removal from the waitlist is 25–30%, but at a MEL of 20, it's close to 50%. So you may have questioned why, the MEL score makes such a difference, that when somebody has a high MEL score, you can't really perform adequate local regional therapy because they don't have enough functional reserve to tolerate these treatments. So that's a very important consideration. And we recently published the result from the MERIT-LT consortium on the outcome of downstaging under the all-comers protocol in 82 patients compared to 230 patients undergoing downstaging using the standard UNOS criteria. The all-comers group had a significantly lower probability of successful downstaging, lower 3-year intention to treat survival, and child B and C are the only predictors of waitlist removal. And you can see here the 3-year intention to treat survival was only 23% versus 66% for those with child A cirrhosis. So again, the same message, those with decompensated cirrhosis, it may be unrealistic to even try to downstage these patients if the tumor burden is very high. We have more updated data that we're going to present in the ATC and also AASLD later in next year. So in this systematic review and meta-analysis involving 25 studies by Darren Tan and colleagues comparing those meeting the UNOS downstaging criteria versus those beyond these criteria, or they had no specified inclusion criteria, you can see that those within the UNOS downstaging criteria has significantly higher probability of successful downstaging, higher probability receiving liver transplant, and lower probability of tumor recurrence. So these are the lessons that we learned. There are upper limits in tumor burden beyond which successful liver transplant after downstaging becomes an unrealistic goal. And we will expect a higher rate of waitlist removal, lower post-transplant survival, higher rate of post-transplant recurrence. Selected patients may still benefit liver transplant with lower tumor burden in regions with shorter waiting time, or if we use living donor liver transplant. So this is a complicated slide looking at the next step. We try to improve our downstaging, which is to combine systemic therapy with local regional therapy in patients who are very difficult to treat. And the systemic therapy, this is in collaboration with Katie Kelly from oncology. We're developing this protocol based on the work by Neil. And then our treatment agents include atezolizumab, pembrolizumab, or durvalumab. So these are some of the agents that we're trying to help accomplish downstaging in combination with local regional therapy. So moving on to tumor marker, first, most important, AFP. So the French AFP model. So this is thinking beyond like just looking at tumor burden. So the French group was the first to officially incorporate alpha-fetoprotein into selection criteria for liver transplantation. So in this French AFP model, they incorporated the largest tumor diameter, total tumor number, and also AFP levels. So they add up the points in this prognostic model, and those with 2 points or less have low recurrence risk. A patient with tumor within Milan, but AFP that's very high, over 1,000, they are at high risk for recurrence. And then there are some HCC patients with tumors beyond Milan, but low AFP, they are low risk for developing tumor recurrence. So this is a French national policy for a number of years. We did a study back in 2014, published in 2014, showing that those within Milan criteria, but AFP over 1,000, had a 5-year survival without recurrence of only 52% versus 80% for those within Milan and with lower AFP. So for a number of years, we already had this internal policy that if a patient had an AFP cut, we applied an AFP cutoff of 1,000, and that would result in exclusion of about 5% of patients from transplant, but a 20% reduction in HCC recurrence. So internally, we required those with AFP at least 1,000 to show decrease in AFP to less than 500 with local regional therapy before we would transplant them. And this approach has actually been adopted as a national policy. And we have validated this approach in an analysis of UNOS data over a 10-year period. You can see that those with AFP over 1,000 going into transplant had worse 5-year survival, under 50%, and this improved to 67% for those with a decrease in the AFP from over 1,000 to under 500, above 100, mostly with local regional therapy, even better at 88% for those with further reduction in the AFP from over 1,000 to 100 or lower. So this validated the UNOS approach to AFP and excluding those with persistently high AFP over 1,000. And this is a nice study by Kareem Hallison, looking at the change in AFP or dynamic AFP response on post-transplant outcome. This is a large international study, over 2,000 patients. The highest rate of recurrence was seen in patients with persistently very high AFP, over 1,000, and those with moderately elevated AFP over 200 or 400, under 1,000 or stay elevated above 200, had moderate risk of tumor recurrence. Those with persistently low AFP less than 200 or more dramatic reduction in AFP from over 1,000 or at least 200 had much lower rate of HCC recurrence. So the change in the AFP over time or dynamic AFP response are really important prognosticators in the field of liver transplantation. And in this second version of the Metro ticket, AFP is now combined with the sum of the number of tumor nodules and size of the largest nodule in estimating post-transplant survival, further highlighting the importance of AFP as a prognostic factor. This is an interesting study by Cocchetti from Italy. This is a little bit complicated, but I'll walk you through this. they look at response to local regional therapy based on the modified RECIST criteria. They suggesting adding that response to local regional therapy to Metro Ticket's second version further improve prognostication. The green bars represent those with transplantable HCC based on less than 30% risk of HCC-related mortality after liver transplantation. The red zone represent high risk for transplant. These patients should not get transplant. And the orange zone represent additional restriction based on the modified RECIST criteria for patients with partial response or stable disease, a few added areas, whereas you see a lot more restriction if patients have progressive disease following local regional therapy. So what about other biomarkers, AFP-L3 and DCP? This is a study from the Mayo Clinic which evaluated all three tumor markers, DCP, AFP, AFP-L3. Out of a total of over 300 patients, only 127 had available samples. That's one of the weaknesses of this study. And a third developed HCC recurrence. 70% of these patients had tumors within malign criteria prior to transplant. You can see that those with high AFP, at least 200, high DCP, at least 7.5, they had the highest risk of tumor recurrence. And those with high DCP, but low AFP using the same cutoff, also, these patients also had significantly higher risk of tumor recurrence. AFP-L3 or absolute AFP-L3, also significant predictors of tumor recurrence. You can see that AFP-L3 of at least 35% in this study, DCP at least 7.5, had higher hazard ratio and also area under the ROC curve compared to AFP of at least 250. So this is a prospective study with support from Fujifilm at our center, and looking at the influence of AFP-L3 and DCP on early post-transplant survival. So this is recently published by Josh Norman with Neil Mehta. And these are patients with tumors within Milan or downstage to within Milan. Those with AFP-L3 at least 15%, DCP at least 7.5, had 3 recurrence-free survival of only 42% versus 97% for all other patients. When you look at this survival difference, perhaps AFP-L3 DCP adds to what we know about HCC going into transplant. Perhaps we can further improve the outcome based on more implementing, these cutoffs in our selection of candidates for transplant. Perhaps if they have high DCP or if they have high AFP-L3, we want to wait and do more local regional therapy and see if these tumor markers will come down before we transplant them. A few studies have suggested a role of FDG PET in prognostication. This is a nice study from New Delhi, India, and look at a combination of AFP, PET-CT, and UCSF criteria in discriminating prognosis after living donor liver transplant in 300 patients. More than 50% of these patients had tumors beyond Milan, 43% exceeded UCSF criteria, and in multivariable analysis, they found that AFP of at least 100 UCSF criteria, beyond UCSF criteria, and PET, FDG PET EVID are independent predictors of tumor recurrence. So they classify these patients into low risk based on 0 or 1 risk factors, moderate risk based on FDG EVID PET, plus either AFP at least 100 or beyond the UCSF criteria, and high risk based on all 3 risk factors, or either AFP at least 100 and beyond UCSF criteria. And you can see that those, based on this classification, 5-year recurrence-free survival went from 89% in the low risk group to 71% in the moderate risk group, 41% in the high risk group. Okay, so this is a summary of the selected prognostic models that have been proposed. The US national policy required tumor burden to be within Milan or downstage 2 Milan. And those with AFP at least 1,000, they are required to show decrease in AFP to less than 500 with local regional therapy. We already discussed about the French AFP model and the Metro Ticket 2 version 2. The HCC Hawk from Cleveland Clinic look at tumor burden and AFP, and then the total tumor volume, AFP, the pre-Moro looking at AFP, neutrophil lymphocyte ratio, the largest tumor size, and then the combination of AFP, PET-CT, UCSF in this latest study from Neil Delling. So the common theme here is that all these prognostic models combine tumor burden with biomarkers. Now, there's a different approach taken by some investigators. Instead of trying to think about how these patients behave, they actually biopsy these tumors, and then they rule out, they would exclude patients from liver transplantation if the biopsy showed poorly differentiated tumor. So both University of Padova and University of Toronto have taken this approach. The Toronto group also excluded patients with cancer-related symptoms, including weight loss or poor functional status. And in this Toronto study, the 5-year survival using extended criteria was lower at 69% versus 78% within Milan criteria, but the difference did not achieve statistical significance. There was also a trend for higher recurrence rate in the extended criteria group. Again, only marginal statistical significance. So do we biopsy these patients all the time? We don't, because one, it's hard to biopsy every patient. And two is that, there are some pitfalls in terms of diagnostic accuracy. The advantage of biopsying is that there may be patients with severely decompensated cirrhosis who can't really tolerate local regional therapy. You biopsy them, you can do prognostication based on the biopsy and decide whether you should go ahead, transplant these patients or not. However, there are inaccuracy of needle biopsy in diagnosis of poorly differentiated grade. You miss this in 8% in the Toronto study and 10 to 20% based on resection data. And then there's a pretty significant recurrence rate and a pretty high rate of vascular invasion. So presented a lot of data. Maybe I can just ask for your opinion in this case, whether you would like to transplant this patient or not. So let me do a quick presentation. This is a 59-year-old man with cirrhosis due to fatty liver disease, presented with an 8 centimeter and 4 centimeter HCC, treated with Y90 twice, baseline AFP5. And then after the treatment, he decompensated, developed worsening ascites, increase in MEL from 13 to 20 within 2 months, and then hospitalized. And, this is Neil Mehta's patient. I was the inpatient attending at the time. This patient was hospitalized 4 months after the last treatment. Total bilirubin is now 32, creatinine 2, INR 1.8, sodium 120. The MEL sodium at the time was 35. Repeat AFP still good, normal 2.8. And so got a CT scan. So this is a partially necrotic tumor, still viable. So tumor diameter here is 7.8 centimeter. And then the second lesion completely non-viable, completely treated. So you're dealing with one viable tumor, 7.8 centimeter. So would you transplant this patient or say, palliative care, no transplant? Let me have a show of hands. how many of you would say, yeah, let's transplant this patient? Nobody. Okay, so that's why I miss the like the in-person grand rounds. You can actually see, so I can't really see very much. How many of you would say, go ahead and transplant this patient? So this is UCSL. We try to push the envelope, so that's probably the answer. So perhaps you can think about, well, we learned this metro ticket version 2. You have a single tumor that's still viable, 7.8 centimeter. So what's the expected survival? 85 to 90% here. So, well, the pros is that, you have normal AFP. That's a good prognosticator. Metro ticket version 2 survival projected to be 85 to 90%. But this is beyond Milan, beyond UCSF, and you don't reach the endpoint of downstaging even with the all-comers protocol. So you can make a valid argument not to transplant this patient. And then, like this looks pretty impressive, but, this is registry data, and I think that we have to take it with a grain of salt. We want more information. So what more information would you like? Let me see if I can see the any information, any more information you want? How about the biomarkers? So AFP-L3, 7%. So in at least our data, less than 15% is good. Some other data like the Mayo Clinic studies, less than 15%. Sorry, less than 35%. DCP 14, so not so good. 7.5 is kind of our threshold. So there's another negative marker here. So how about PET-CT? So we reviewed this study. So PET may be at prognostic value to kind of evaluating patient for transplant, and this patient is PET negative. More information. Okay, so biopsy. Okay, so we want to make sure that biopsy does not show poorly differentiated tumors. So we decided, I talked to the surgeon, I talked to John Roberts and say, why don't you take an offer for this patient and then do intraoperative biopsy. If it's poorly differentiated tumors, then you should exclude this patient. You should not transplant. If you see well or moderate differentiated tumors, you can go ahead and transplant this patient. And I talked to the pathology. I said, how good is a frozen section for poorly differentiated tumor? And the pathology said it's actually very good, very reliable when you do it intraoperatively. So this patient got an offer, and intraoperative biopsy showed well to moderate differentiated HCC. So we went ahead and transplanted this patient. So the next question is, how does this patient do? So he had recurrence. He had recurrence of HCC. No matter how thoughtful, how careful we are, we are not, necessarily great in terms of prognostication or prediction. But this recurrence happened pretty late. That's the information I just checked with Neil. And he recurred pretty late, and he's still alive right now, 5 years out from transplant. So it's really a judgment call whether you think it's worthwhile, doing a liver transplant, even though this patient is not tumor-free, he's still surviving, is still 5 years out from transplant. So is it worth pushing the limit? I don't know. But I think that we've done the best we can in terms of like giving this patient the best chance of surviving, and based on all the data, all the studies that we looked at to make that decision. So just the last 5-10 minutes, I would like to just touch on a couple things that we have done, that we're trying to explore. One of the challenges for us is really that the waitlist prioritization is not great. We're giving the same priority to a patient with a single tumor, 2 centimeter, versus somebody who has 3 lesions being downstage to Milan. They get the same priority. We have to kind of do a better job in terms of prioritization. So we have always been very interested in, looking at the factors predicting dropout, and also how can we prioritize patients for transplant. Some time ago, study with Neil suggested, when a patient has single tumor, 2 centimeter, complete response to local regional therapy, low AFP, they have only a 2% probability of dropout in 2 years versus 27% for all other patients. And that patient still get the same priority. So we like to do more in-depth analysis of waitlist dropout. So this is a somewhat complicated study that was recently published. So we analyzed the UNOS database and developed this dropout risk score based on MEL sodium, child Pew score, AFP, and also tumor burden. In a training set, we looked at patients from long wait time regions and identify subgroups at different risk of dropout. And then, the thinking is that we don't want to, give those patients high priority if they turn out to do poorly after transplant. So we also examine post-transplant survival in the short wait time regions according to the different categories of dropout risk score. And we found that those at highest risk for dropout also had reduced post-transplant survival here. And the cutoff here is a risk score of over 30, primarily in patients with high AFP and maybe those with multifocal disease and high MEL score. So there's a subgroup of patients that we probably should not transplant them, even though they have high risk of dropout, because they may have poor biology and not do as well after transplant. And finally, I just want to highlight the knowledge gap, important areas of future research related to post-transplant management of HCC patients. And these points were clearly summarized in the AST Liver Intestinal Committee Practice Position paper by Betsy Varner. So we know that we have no standardized surveillance strategies for recurrent HCC after transplant, no proven adjuvant therapy to reduce the risk of HCC recurrence. Long-term survival can be achieved in a subset with local recurrence. There's a need for a risk score to more accurately assess individual risk for tumor recurrence after transplant. So there are few post-transplant models based on explant pathology. These are not selection criteria. This is, more, intended to provide prognostication based on pathology to decide on how we screen these patients for HCC recurrence, and also perhaps stratify patients according to the risk of recurrence so that we can select patients for adjuvant therapy if they become available in the future. So examples include the HCC consortium, the retreat score, and the post-moral model. So we have developed and validated a risk score we call the retreat score. This is a multi-center study involving UCSF, the 2 Mayo clinics, based on more than 1,000 patients. My only contribution to the study is to come up with the name RETREAT, which stands for Risk Estimation Tumor Recurrence After Transplant. So the retreat score was developed based on 3 factors that independently predict tumor recurrence: the AFP at liver transplant, microvascular invasion, and also the sum of the largest viable tumor and the number of viable lesions. The nice part about this is that we really take into consideration local regional therapy prior to transplant and only consider the viable tumors. So you add up the points here. You can have a retreat score of 0 if the patient has no viable tumor, no vascular invasion, and low AFP. So you can see that the 5-year probability of recurrence was less than 3% for those with a retreat score of 0, up to 75% for a retreat score of 5 or greater. So we modify our surveillance strategies after transplant. We actually don't do screening for those with retreat score of 0, and then we tailor the screening strategies, both duration and intensity, according to the retreat score. So we'll see if that approach is really justified with more time. So to summarize the knowledge gaps, challenges, and priorities for research in liver transplant for HCC, I think that we have made some progress in terms of selecting candidates for transplant. We have made some progress in tumor downstaging, biomarkers, but there's still a need for more research to develop and discover new and potentially better biomarkers, and then understanding how to integrate the available biomarkers with tumor burden in the transplant selection criteria. We definitely need more refinements in transplant waitlist prioritization. We need to standardize the post-transplant surveillance strategy. And then we absolutely need more adjuvant therapy right now. We made a lot of progress in systemic therapy. How to use those without risking rejection is a major challenge. So more adjuvant therapy to reduce the risk of tumor recurrence, especially in these high-risk patients. So there's still many areas that we can do better. So this is a summary of what we do and the current landscape. Thank you very much for your attention.